Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Manoj Toshniwal. Sir, welcome to our platform.
Thank you.
Sir is an MBBS MD, internal medicine, DM clinical hematology, BMT fellowship, consultant hematologist at Jeevan Amrit Hospital, Arunabad. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is pantio, sorry, pancytopenia approach. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you, Sriyan. Thank you, IGCB Group, for this wonderful platform. So, without much delay, we will start. Can you please put my slides so that we can start the discussion? So, thank you so much. So, today we are discussing about pancytopenia approach. So, it is actually the pancytopenia means all the cells are down when hemoglobin is low, when WBC count is also not at the mark, and platelets are also low, thrombocytopenia. So, for that, first we need to learn how to interpret that CBC. Many times we come into the situation where people call that patient as thrombocytopenia, platelet count is around 70,000, but they completely miss that hemoglobin is around 8, the WBC count is 3,800. So the interpretation of CBC at first, and then if at all the bone marrow engine is not working, we need to see. So I am Dr. Manoj Toshniwal. Today we'll be discussing about CBC interpretation and the conditions where bone marrow engine stops working. First of all, I thank this IGCP group. I thank all of you who have put your efforts in making this webinar happen. I also thank all the doctors on this weekday in this festive season and in the evening if you are joining here to discuss something scientific, to learn something good. I'm really appreciating you for your effort and I deeply thank you all for being available here. You all are experts. You have busy OPDs. You see many patients daily. I am no one in front of you all. Sorry. I know a little bit more about this CBC, being hematologist, and that is why I am someone who is delivering the lecture today. Today, I want this to be a dialect. I want this to be a session where we are discussing about pancytopenia together. We all see cases in daily practice where they have pancytopenia and we are in dilemma what to do, how to go ahead. It is universal. It's for physicians, surgeons, orthopedicians, gynecologists, general practitioners, all the doctors. At some point of time, surely they come across to the one or the other case who is having pancytopenia. And that is why I feel that if any question is there, please drop in the question and a box so that at the end of the session we can discuss. Being a doctor, it's always this is our quest to find the cause. My boss used to say, anyone can treat, but to diagnose a case, that is what you need. And by diagnosing that to the pinpoint, you can say whether someone has a right problem or you are dealing with that problem rightly or not. So today we will be discussing how to find the problem in cases of pancytopenia, what to suspect, when to suspect, how to evaluate. It all starts first with the CBC, the complete blood count. At the start of session only I told many times we get a call from physician or general practitioner that patient has platelet count being low, but they completely forget to spend some time and see about hemoglobin, about total leukocyte count. And that is why we start this session with discussing upon how to read this complete blood count how to interpret that complete blood count completely. This is how we get the CBC. It is hemoglobin. The RBC and hematocrit are one and the same. Then comes the RBC parameters. Then comes the total leukocyte count. Then comes the differential leukocyte count. Then comes the platelet indices and platelet count. We have nowadays 3 part, 5 part, 6 part, even 7 part filters, which give much more information. We just need to spend some time and see that report, that graph rightly, so that we can get best out of it. Almost every patient who is entering to your OPD has that CBC report with them, but we don't have that much of time to read it completely. That's the problem. In this, these are the main parameters which we have already discussed. When it comes to the pancytopenia, three cell lines being low, that is hemoglobin, total leukocyte count, that is WBC count, and the platelet count. If all three cell lines are low, we call it as pancytopenia. If one cell line is low, yes, we call it as monocytopenia, or depending upon that, if hemoglobin is low, anemia. If TLC low, leukopenia. If the platelet count is low, we call it as thrombocytopenia. So whenever WBC count, platelet count, hemoglobin, everything, something is low, it is must that we have that manual microscope. We are in the era of artificial intelligence, but still we can't replace what we can see by our eyes. So it is needed to confirm the WBC and platelet values by the analyzer. We see cases which are EDTA induced platelet clumping, where analyzer gives platelet count very low because of EDTA induced platelet clumps. But when we see under the microscopy, we can realize that yes, it is platelet count being normal. We that repeat it in other reagent, that is citrated or heparin burn, and platelet count comes normal. So confirmation of indices under microscope is something which we all should have a habit of. It gives much more information about morphology of RBCs, what is the size, what is the color, how is the shape, whether someone has megaloblastosis, someone has teardrop cells, and depending upon that, diagnosis varies. And that is why seeing peripheral smear is very important when it comes to the abnormal CBC report. We also need to interpret WBC count by individual cell lines. How is the maturation of WBCs? Whether we see some abnormal cells or blast. So whenever CBC report is not good, have a habit to give a call to your friend who is sitting in the pathology and ask him, please can you review that peripheral smear for me, and he will happily do it. If that gives you some as a clue for the diagnosis, that is well and good. We all know RBCs, they are red blood cells. They help to carry your oxygen to the lungs, and from tissues carbon dioxide to the lungs. So they are produced from bone marrow, and these are the cells which are very important cells in our body. Usual value is around 5 million per microliter, but whenever it is low, we call it as anemia. Anemia is such a common condition in our India that we take a value of even 10 as a normal hemoglobin. But that should not be the thing when it comes to the seeing patients in our OPD. We should stick to the parameter that anything less than 13 is anemia. We should get to the bottom of it and treat that accordingly. So anything less than 13 for a normal adult person, if it is less than 12 for a lady who is pregnant, we call it as anemia. If anemia is there and along with that RBC count is good, means hemoglobin is around 9 and still RBC count is 5.8 million, we can think about thalassemia minor. Usually they have microcytic RBCs where the hematocrit is on higher side, but still the RBC count and hematocrit is on higher side, but still this MCV is very low, around 50-60, and those cases can be because of the what you call thalassemia minor. So MCV gives us idea about what is the type of anemia. If they are low, we call it as microcytic anemia. If they are normal, we call it as normocytic anemia. If it is large, macrocytic, it can be megaloblastic or MDS. Depending upon the mean corpuscular hemoglobin, we call it as hypochromic, normochromic, or hyperchromic when it is hemolytic picture. MCSC and RDW gives the idea about the fragmentation of your RBCs, and if it is on a higher side, patient can have hereditary spherocytosis. We need to evaluate about the same. So these are the parameters we need to see when we see hemoglobin being low. So just spend some time. What is the hemoglobin value? If hemoglobin is around 8, 9, 11, even 12, patient is anemic, and see what can be the cause of anemia. Most of the time, it is because of the nutritional causes, iron deficit anemia, microcytic anemia. It can be anemia of chronic disease, anemia of infection, thalassemia, sideroblastic anemia. When it is macrocytic anemia, it can be because of the vitamin B12 folate deficiency, hemolysis, or MDS. But we do commonly see early IDA or combined deficiency where patient has nutritional deficiency of both iron and vitamin B12 leading to the normocytic anemia. So whenever we are reading CBC, have a habit to see hemoglobin. If it is low, see the RBC indices so that we can catch what is the diagnosis of anemia. Reticulocyte count, whenever a hypoproliferative state is there like nutritional anemia, reticulocyte count is low. But if the reticulocyte count is on higher side, it can be because of hemolysis or chronic blood loss where marrow starts to produce more. You see microcytic anemia and you start treating them as iron deficiency anemia or you want to evaluate. But because of the cost reason, many times it's not possible to complete evaluate. First test which we all should do is the ferritin test. If ferritin is low, yes, it is iron deficiency. But if ferritin is normal, we should do the iron studies. It has to be done in fasting state where we can get high TIBC, low serum iron, low serum ferritin, and even low transferrin saturation. If transferrin saturation is low, it can be because of iron deficiency anemia or even anemia of chronic disease where functional iron deficiency is there. So, doing iron studies helps in diagnosing the cause of iron microcytic anemia. Iron studies are very labile and make sure that you are doing it very rightly in fasting state where you can interpret the result rightly. Ferritin is acute phase reactant. Many a times it is labile and it comes high if patient has infection. So if you are suspecting iron deficiency anemia, patient has acute phase or liver injury or iron loading, better to get the iron studies in the fasting state which can give you the clear picture of transferrin saturation, and if it is low it can be iron anemia or anemia of chronic disease for sure. These are the WBCs which all should pay attention when WBC count is on higher side. If it is neutrophilia, it can be because of bacterial infection, some tissue destruction, some inflammatory arthritis going on. Thyrotoxicosis can be a cause where WBC count is on higher side with neutrophilia. Smoking, steroids, and it can be because of leukemia. And in that case, we need to see the peripheral smear for sure. Platelets are small, tiny cells in the peripheral blood, and make sure that you pay attention to the platelet count, which should be normal. Even subtle platelet count being low, WBC count being low, can be a sign of early cirrhosis of liver with hypersplenism. So, paying attention to the platelet count, even if it is 130, 140, yes, it is important to catch the disease early. These are various causes. Many times we see even in pregnancy. But if it is pregnancy related, it can be gestational thrombocytopenia, where platelets are low at the range of 70, 80,000 in second or third trimester of pregnancy. It can be early sign of eclampsia or preeclampsia. HELP syndrome is one of the cause for thrombocytopenia, which can be detected early by seeing the platelet smear or paying attention to the platelet count. And other causes like TTP, ITP, autoimmune disorders, infection, DIC, anything can be there on this planet when platelet count is very low. So paying attention to the platelet count is something also important. So far so good. We know that CBC is something which needs to be completely read. Pay attention to all the parameters rather than just seeing hemoglobin or your platelet count. Pay attention to all the other parameters like RBC indices, WBC indices, or even platelet indices so that you can get maximum information out of it. If you see a pancytopenia, that is hemoglobin is low than normal, WC count is low than normal, the platelet count is also lower than the normal, in that case, yes, what it is needs to be evaluated for sure, and it is the case where your bone marrow engine may not be working properly. So, when we see a pancytopenia, these can be the causes. And today we will discuss mainly on the decreased production, because other two causes are simple, easily given. First is sequestration. So whenever patient has pancytopenia, always have a habit to have the per abdominal examination to see the spleen size. If spleen is enlarged, that's the cause why someone has pancytopenia. Then evaluate why spleen is enlarged. It can be tropical splenomegaly. It can be early cirrhosis or cirrhosis of liver leading to the hypersplenism, or it can be some hematological problem leading to the splenomegaly like myelofibrosis, lymphoma, hairy cell leukemia, anything can be. So, sequestration, they get sequestrated in the spleen, and that can cause the pancytopenia for sure. Second cause can be destruction of cells. Whenever there is sepsis, whenever there is DIC, yes, RBCs get destructed, WBCs get utilized, and because of peripheral destruction, platelets are low. So these can be the causes. But now, when we are discussing about when engine fails, the marrow failure can be there. It can be because of aplastic anemia, medicines like methotrexate induced pancytopenia, azathioprine induced pancytopenia, antibiotics like piperacillin tazobactam induced pancytopenia. So this can be there. Various infections also can cause marrow failure by causing damage to the marrow. Nutritional causes like vitamin B12 deficiency is one of the common cause of pancytopenia in India, where patient has severe vitamin B12 deficiency. Bone marrow becomes hypercellular with erythroid hyperplasia, and because of marrow infiltration by these normal cells, they fail to produce normal CBC. So, pancytopenia because of marrow failure. It can be because of infiltration of marrow by other cell lines like leukemia, myeloma, MDS, metastasis. Many times we see patient has urinary difficulty, pancytopenia. We do the marrow and we see a prostate infiltration. Patient has some breast mass not getting evaluated, pancytopenia. We see the marrow and breast malignancy with metastasis in the bone. So, malignant disorders or even non-malignant like storage disorders, infections, or even myelofibrosis. So, myelofibrosis may be because of primary myelofibrosis or secondary myelofibrosis, secondary to the various autoimmune disorders. So, these can be the various causes when it comes to the bone marrow failure. We will just quickly go through one by one causes. So these can be various causes, multiple reasons can be there when it comes to the pancytopenia, like vitamin B12 folate deficiency, bone marrow infiltration, aplastic anemia, hypersplenism, leukemia, immune dysfunction, autoimmune disorders, viral or any other microbiological infections, disease infiltration leading to them, myelodysplastic syndrome. Some radiation or chemicals can damage the marrow. So anything can be there. And how to diagnose them is by the complete evaluation. First, see whether it is decreased production, increased destruction, or sequestration. If you see spleen, go by that. If increased destruction, go by sepsis. If decreased production, yes, only thing which can give you the diagnosis is bone marrow. This is a classical case of megaloblastic anemia. Patient comes with classical knuckle pigmentation, tongue dark, ciliated or geographic tongue is there. Patient has peripheral neuropathy and difficulty in walking and pancytopenia. You see the peripheral smear, you see this macrocyte, macroovalocyte, teardrop cells, hypersegmented neutrophils. Even some Howell Jolly bodies are there in the down. So yes, this is classical picture of megaloblastic anemia, second due to the vitamin B12 deficiency, which is rampant in our country. But we can't miss a diagnosis of leukemia. So whenever in doubt, better to get the marrow out. That's what we say. Sorry. So yes, for these cases, when we do marrow, We see florid erythroid hyperplasia with megaloblastosis is there, where RBC maturation is arrested at this phase because of lack of vitamin B12 in the body. You give vitamin B12, either injectable or oral, and they start responding beautifully. But we should not stop at that level. We should replace that vitamin B12 properly and counsel that patient about the right diet. That is animal food. Many a times patient is vegetarian. We diagnose the vitamin B12 deficiency. We start treating them with this uh, vitamin B12 replacement, but ultimately we don't counsel them rightly, and that is why they don't respond, or even they relapse again because counseling was not. So diet counsel is very important. You need to go for animal origin food, which is non-vegetarian food, or even milk product. They only contain vitamin B12. Otherwise, vegetarian food doesn't have vitamin B12. In that case, you need to go buy some dry fruits or 3 monthly injection of vitamin B12 or oral replacement of vitamin B12 as a supplement, so that megaloblastic anemia doesn't happen again. Second thing in the diagnosis is hypersplenism. Hypersplenism is a condition where spleen is enlarged or may not be enlarged also, but is hyperfunctional, leading to the increased destruction or sequestration of these cells, and is mainly many a times because of the cirrhosis of liver. Because of the cirrhosis of liver, it gives various chemokines and various exosomes into the blood. It also causes portal congestion, which leads to the splenomegaly, and blood cells gets sequestrated into the. This can be there. So, by complete evaluation and liver workup, we can get to the bottom of it. Whenever suspected hypersplenism there, do UAG abdomen with hepatoportal Doppler to see the portal congestion. Get the upper and lower GI to look for varices, and gastroenterologist opinion, so that we can get to the bottom of what is the cause of cirrhosis of liver. If the GI workup is normal, then in that case, bone marrow is something which should not be delayed, because splenomegaly can be there because of various blood malignancies like lymphoma, which can be just there in spleen, splenic marginal zone lymphoma. Periphery will not have anything, patient will not have any lymph nodes, but it is highly treatable disease, and we should not miss that. If the bone marrow is normal, liver workup is normal, it can be because of some storage disorder, or mainly because of the tropical splenomegaly, chronic typhoid, chronic malaria, chronic infections can lead to this tropical splenomegaly. And we need to evaluate that and treat if patient is symptomatic. Directly suggesting splenectomy is something which should be avoided when it comes to the hypersplenism with pancytopenia. Autoimmune disorders are something which usually missed when we see pancytopenia. Young female coming with pancytopenia, inflammatory arthropathy can be autoimmune disorders. Commonly, it is because of the immune mechanism due to SLE, but uncommon causes are like hemophagocytic lymphohistiocytosis, HLH. It can be very detrimental if we miss it, because it is a fatal disease where patient can have ferritin being very high, triglyceride being very high, hyperfibrinogenemia, hemophagocytosis in the bone marrow, and soluble CD25 is very high. There is massive activation of macrophages in the marrow, leading to multilineage separation. Bone marrow toxicity because of the medication or infection is also common in SLE, because they are on azathioprine, they are taking methotrexate, they are taking various immunosuppressive drugs. And that is why, keeping in mind some patient has autoimmune disorder and pancytopenia is there, think about marrow to rule out marrow toxicity versus megaloblastic anemia. Some hematological malignancy can also be there in patients who are young, SLE, presenting with pancytopenia. Seeing peripheral smear properly and, if needed, doing marrow at right time is something which is needed. Multiple autoimmune cytopenias can be there, which is Evans syndrome or autoimmune anemia, or even autoimmune myelofibrosis can be the cause when it comes to the SLE with pancytopenia. So autoimmune disorders can be the reason why someone has pancytopenia. By thorough clinical examination and proper guided evaluation of that particular condition, that is what something is needed for these patients. Fourth thing which today we will be discussing is aplastic anemia. We can see these marrow reports, marrow slides, bone marrow biopsy. One on the left shows full of cells. These are bluish colored cells. These are myelocyte, beta myelocyte, erythroid cells. Another one is empty marrow. These are fat spaces. So whenever bone marrow is replaced with the fat spaces, we call it as aplastic anemia. And pancytopenia with severe lymphocytosis, like 80% lymphocyte, always be suspicious that your patient might be suffering from something like aplastic anemia, which can be diagnosed with the bone marrow biopsy at the earliest. Rather than spending or wasting time in treating them with other things like steroids or some supplementary medicine, get the marrow done early and start treating. Aplastic anemia is not malignancy, but it is very bad disease when it comes to the severe pancytopenia. And that is why diagnosing them early and starting treatment early is good. For them, we start usually with cyclosporine, danazol, and the newer drug L-trombopac, which stimulates the stem cell for production of platelets and other cell lines as well. With these newer drugs, nowadays prognosis of aplastic anemia is getting better and better day by day. We do have anti-thymocyte globulin or even bone marrow transplant as curative option for patients with aplastic anemia with cure rate nearing around 80-90%. And that is why on-time diagnosis and guided treatment is something which is advisable to this very fatal disease, aplastic anemia. Other condition which is equally or better to not to be missed is acute promyelocytic leukemia. They most of the time present with pancytopenia, and you can see this blood picture where they have shown multiple R rods embedded in the myelocytes, promyelocytes. And these are called faggot cells, and it is classical aplastic anemia with buttock shaped myelocytes, promyelocytes. It is a very high grade malignancy with initial mortality being very high. But these patients do respond beautifully to the treatment when we give arsenic and all trans retinoic acid to the day. Arsenic needs to be given almost daily for 28 days and all trans retinoic acid also. If WBC count is on lower side, that is in pancytopenia seen, if you catch them, it is early or low risk disease where the chances of surviving from this disorder is nearing 100%. So, not to miss in the early phase is something which is important. So, a patient with pancytopenia, some bleeding symptoms are there. If gum bleeding, petechial hemorrhages are there, even at the platelet count of 30, 40, 50,000, you might be dealing with something like APML. We see a scenario where patient has platelet count low, they go to the physician thinks that it looks like ITP and let's give the steroids. They give steroid, WBC count next day become from 3,000 to 7,000, and then last on third day it becomes 18,000. We think it is because of the steroids. Yes, it can be because of the steroid if it is IT, but if it is APML, it can be because of rapidly proliferative acute promyelocytic leukemia. And now, because of delay in 2 days, patient has gone from low risk disease to the high risk disease, where chances of DIC and bleeding are high. So that is why for every patient who has pancytopenia, always have a habit to ask your pathologist to see the smear, and whenever in doubt, get the bone marrow as early as possible so that we don't miss cases like aplastic anemia or acute promyelocytic leukemia, which has very good cure rate. This is one more case, that is hairy cell leukemia. You can see those patients, these cells which have hairy projections. And yes, they present late in life. They have splenomegaly B symptoms and severe pancytopenia. This disease is also highly curable. One cycle of cladribine based chemotherapy and it is almost cured. And that is why not to be missed. So whenever a patient has splenomegaly, pancytopenia, peripheral smear is normal, some lymphocytosis with cells showing such type of hairy projections, liver workup is normal, better to get the marrow out. Usually marrow shows secondary myelofibrosis because of these hairy projections. And this malignancy is highly treatable. We have that BRAF mutation which we can do on the blood. If BRAF mutation is positive, it is sine qua non for this diagnosis. You give one cycle of cladribine, it is cured. So that is why not to miss hairy cell leukemia in patients who have pancytopenia with splenomegaly. So up till now, we have discussed these cases of pancytopenia where we can have most common diagnosis megaloblastic anemia, or it can be because of autoimmune dysfunction like SLE. It can be because of hypersplenism when liver disease is there. It can be because of blood disorders which are very curable like aplastic anemia, acute promyelocytic leukemia, and hairy cell leukemia. These are the disorders which are highly fatal, but if diagnosed in time, they can be very curable. And that is why I always have a habit to read that CBC completely, see the peripheral smear properly, and if in doubt, get the marrow out as early as possible. Other one diagnosis is primary myelofibrosis. They keep on coming to your OPD for some or the other general symptoms like weight loss, body ache, fatigue, bony pain, all those things are there. You see the WBC count is on lower side, hemoglobin is on lower side, spleen is just palpable. You feel it is megaloblastic anemia, you give vitamin B12, you give vitamin B12. But it can be primary myelofibrosis where peripheral smear can show this leukoerythroblastic blood picture with teardrop shaped RBCs, the nucleated RBCs, the myelocyte metamyelocyte in the blood picture, and these can be classical cases of myelofibrosis which have very good prognosis if treated early. There are drugs for it: lenalidomide, thalidomide, dinazole, systemic steroids, JAK2 inhibitors. These are the things which can keep them alive for years together. 10, 15, 20 years they can be there. But if diagnosed in time. If not diagnosed in time, once it becomes rampant, if splenomegaly is used, treating them becomes very difficult. So, diagnosing early a case of primary myelofibrosis is always pleasurable to the doctor and also to the patient. Other cases usually we see in ICU. These are HLH. Briefly, we discuss this diagnosis in patients of SL. Patient has autoimmune disorder, fever is not going on, and severe pancytopenia is there. You see the smear, nothing is there. But if you see the marrow, you see these macrophages which are engulfing these cells. And this is macrocyte activation syndrome or hemophagocytic lymphocytic. For diagnosis of this disease, you need to do these blood tests where you can uh, come to the bottom of it by seeing these whole parameters. Out of these 7 parameters, at least 4 should be there. Patient should have hepatosplenomegaly, ferritin on higher side more than 1000, usually in 10,000. Triglycerides also high. Hypofibrinogenemia, fibrinogen becomes low. Hemophagocytosis in the bone marrow, increased soluble CD25, and patient has pancytopenia. These 7 parameters, out of these 7 parameters, if something is positive, out of 7, 4 are positive, you can have a strong suspicion of hemophagocytic lymphohistiocytosis, which has to be dealt as early as possible by starting steroids because it can go into multi-organ failure and can be fatal quickly. So, it can be there. That is why we need to see the peripheral smear and do the bone marrow biopsy. So We have discussed these few cases of pancytopenia and how to approach them. To summarize my talk today, let's have a habit to read complete blood count completely. It is usually seen that physicians, general practitioners, and doctors being so busy, usually we miss the early diagnosis by not spending that 10 seconds with that CBC. Just whenever patient has platelet count low, always have a habit to see what is hemoglobin, what is WBC count, which gives a lot more information about the diagnosis and treatment as well. If hemoglobin is low, less than 12 is low rather than कम ही रहता है. No, it is low, less than 12 is low, and we need to evaluate. Platelet count 1.3 is also low. WBC count 3900 is also low. Yes, we need to understand that. We need to pay attention to that and start evaluating. If someone has count low, it guides you further evaluation like iron studies, serum ferritin. These are important information. If doubt is there, always have a habit to see the peripheral smear. Peripheral smear seeing is always important. And that is why if pancytopenic case come to you, get your phone, call your colleague and ask him, request him to see the peripheral smear of that particular patient so that you can get the most of the information out of it. And whenever in doubt, get early evaluation, early treatment to avoid the fatal complications because many of the blood disorders like aplastic anemia, acute promyelocytic leukemia, hairy cell leukemia, hemophagocytic lymphocytic histiocytosis, they are very treatable, but they are very fatal if missed in the early period. Doing extra evaluation may cost you little bit amount, but if not doing is costing for the life, then it is always better to get it done. Step by step, read CBC completely. If doubt, see the peripheral smear. If doubt, rather than waiting, get the bone marrow as early as possible so that we don't miss the diagnosis of case who is having pancytopenia. This is all from me for today's discussion. Thank you everyone for your patient listening and attention. And session is open for the question and answer. Over to you. Thank you.
Thank you so much, sir, for your wonderful presentation. We have few questions from our audience if you like to take that up.
Yes, thank you.
Thank you, sir. So, sir, the first question from our audience is, how do you monitor and follow up with the patients who have been diagnosed and treated for pancytopenia?
So, important question. Keeping follow up is also important. You see a case who has pancytopenia, you see the smear, you think it is megaloblastic anemia, you start them on vitamin B12 replacement, and they are not seen for next 3 months, and then they come with some malignancy. So, whatever you are treating, give a follow up date. Ask them to come and give you the follow up. Recently, I have one patient who had lymphadenopathy, pancytopenia. Initially, tuberculosis was suspected by the physician. AKT was started, and he was not in the clinic for 4 months. Now has splenomegaly, bone marrow shows lymphoma. So yes, keeping follow-up of patients of pancytopenia, whatever you diagnose, is very important. Maybe in 1 week, 2 weeks, 3 weeks term, depending upon the severity of that pancytopenia and the suspected diagnosis, is something new. For a patient who has aplastic anemia, they always have tendency to bleed, and that is why keeping them in weekly follow-up and as and when needed blood transfusion is something which we all practice. So these are all. Thank you. Yes.
Thank you
Any
so much,
question?
sir. Yes, another question from our audience is, what are the latest developments and research in the field of pancytopenia and how might they impact clinical practice?
Yeah. Thank you so much. This is very important. Initially, pancytopenia was a difficult diagnosis because non-availability of hematologist, non-availability of trained person to get to the bottom of it. But now almost every city has hematologist, have a tendency to see the peripheral smear, have a tendency to see the marrow, have a tendency to get to the diagnosis as early as possible. It is something which is a incredible development. That is what I would say. Disorders also, whatever you diagnose, you can treat nowadays. If you have hairy cell leukemia, cladribine is available, easily available, not that expensive, and it is highly curable. Aplastic anemia, patient has aplastic anemia, but ATG, L-thrombopac, rombiplastin, they are making difference in the life. Acute promyelocytic leukemia, highly treatable malignancy. So yes, pancytopenia treatment is now available. That's the most important thing. That's the most important advance I would say in patients of pancytopenia. Thank you.
Thank you, sir. The next question from our audience is: are there specific guidelines or algorithms for the management of pancytopenia that doctors should be aware of?
Yeah, as a very important question, because as a doctor, as a science person, we are used to have the algorithm how to go about. In today's discussion, also we went step by step, and I started my talk with CBC. Let's read it completely. So, first thing which we all miss is we just don't pay attention to the pancytopenia. So first thing in algorithm is pay attention to the CBC, see all the values, and then go step by step whether you are suspecting increased sequestration, increased destruction, or decreased production. If you are suspecting decreased production, always better to get the bone marrow biopsy done at the earliest so that you can diagnose what is the cause of pancytopenia. And depending upon the cause of pancytopenia, you need to treat them accordingly. So yes, algorithm is CBC, peripheral smear, bone marrow, and if needed, start the treatment as early as possible. Thank you.
Thank you, sir. The last question from our audience is: how can you manage complications associated with pancytopenia, such as bleeding and infections?
So very important. Pancytopenia, why we are insisting that it should not be missed or diagnosed early is because of these complications. Whenever patient has hemoglobin low, they feel tired, weak, fatigued, shortness of breath, decreased working capacity, everything comes. Whenever WBC count is low, it is the main immunity of your body. And if WBC count is low, they come with various infections like pneumonia, wound healing being hampered, kidney infections are there, opportunistic infections are there. And by the time they come to the final diagnosis, they catch some infection. Third thing is platelet count. If platelets are low, chances of bleeding are very high. And that is why these patients, by the time they come to the hematologist or final diagnosis, they have one or the other complication. So for that, they need to be educated rightly that you have WBC count low. By the time we get to the bottom of it, start to follow the neutropenic precautions, like COVID like precautions. Avoid meeting to the people, use mask, use sterilium, have sterile food so that you don't catch any infection. If platelets counts are low, always say them that don't have a risky behavior like playing something, falling on something, which can lead to a extensive bleeding. Avoid intramuscular injection, avoid some surgeries, avoid some other drugs like steroids or even Ayurvedic medicines is also very important advice so that we don't land up in infection or some bleeding. And if hemoglobin is low, give them transfusion to keep hemoglobin more than 7. If platelets are low, give them transfusion to keep that platelet count more than 1, at least 20,000. By the time we get to the bottom of the diagnosis, start treating them early. So, counseling of the patient, neutropenic care, and transfusion support is something which is needed for these patients who are suffering from pancytopenia. Because if you don't do at the earliest, they can land up in complication, and if complications are whatever you diagnose, it is very difficult to treat if patient is not in position to accept that treatment, not in position to get treated for the same. And that is why it is important to avoid the complication. Thank you.
Thank you so much, sir. Before concluding today's session, any last comments from you?
So thank you everyone. This was very good 45 minute session for your attentive listening about pancytopenia. And I thank Shriyan and IGCP group for providing me this platform, to providing this platform to all the doctors, which can discuss and share their thoughts with each and every individual in the group for better health, better education, and sharing of their ideas. Today we discussed pancytopenia. Maybe next month we'll have some other topic and come back to you, and we'll keep growing through this platform. Thank you so much.
Thank you so much, sir, for joining us today. With your permission, I would like to conclude to this session. Thank you, sir.